Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Welcome to About the Face. I'm your host, Chang Ma. Today we'll be talking about facial paralysis and looking at trends in clinical management and adherence to guidelines, which is discussed in the recently published article, Evaluation and Treatment of Acute Facial Palsy, Opportunities for Optimization at a Single Institution. To discuss this with us, we're joined by the author, Dr. Danielle Eytan. Dr. Eytan is a dual board certified facial plastic surgeon and otolaryngologist, also a clinical associate professor at NYU. She specializes in treatment of facial nerve paralysis and facial reanimation. We're thrilled to have her with us today.
Thank you so much for having me. It's great to talk about this topic with other interested people and spread the word about it.
Yeah, and I think this is a very important topic, especially in the world of ENT and facial plastics. Specifically, facial paralysis is a big topic and encompasses a large part of our training and practice, but can get maybe a little bit less exposure in the public space and amongst other specialists. So would you mind introducing the topic to some of our listeners and explaining why facial paralysis and specifically Bell's palsy is such an important topic?
Absolutely. So, there's a lot of different reasons why patients will have facial paralysis, Bell's palsy, of course, being the most common one. There was a 2025 paper with an estimate of 15 per 100,000 adults per year in the United States will have Bell's palsy, which is a fairly significant number. And I think many of these patients are told, don't worry, this goes away. And for many of them, it does. But the reality is about 30-something% of patients with true Bell's palsy will develop synkinesis or an aberrant reinnervation afterwards. And the vast majority of those patients have no idea that this is something that we can treat. So there's more that we can be doing for that subset of patients. On the other hand, there are patients where they're diagnosed as Bell's palsy in the ER or by their primary care physician when they have onset of paralysis. But the reality is there's some underlying occult neoplasm or other source of their paralysis that hasn't been fully elucidated. These are two very different reasons, but all come back to the same thing about why otolaryngologists and facial plastic surgeons in particular are at such a great position and an important position to interact with our colleagues in other fields and bring greater awareness to the role that we play and to the possibilities for this patient population.
I totally agree. I think with our specialty as otolaryngologists and for you, especially as a facial nerve specialist, there is a distinct responsibility to both bring awareness to this. And like you said, it's very treatable. Some 70% of patients have full recovery after receiving the appropriate regimen. So it is a point of discussion that this is being treated in the right way and adequately. And to discuss that a little bit, as physicians, we often like to say that we practice something called evidence-based medicine, which is kind of a roundabout way of saying that when treating patients, we tend to follow guidelines based on trials and studies that generate a vast amount of evidence either for or against that specific treatment protocol. But in many instances and scenarios, physicians may have individual practices that form based on their experiences working with certain populations or other patients in the community. In a sense, to create a more cohesive treatment algorithm and to generate a consensus, we produce these clinical practice guidelines, which dictate treatment for things that follow a very predictable algorithm. So briefly, could you walk us through how the guideline for something like Bell's palsy is generated, and how can so many different practice styles and opinions be brought together using something like a clinical practice guideline?
Sure. So with guidelines, they're usually a combination of expert opinion brought together with evidence of different studies that have been done in the past. So each society tends to create their own guidelines, and that's an important point for this because in our study, we found that while we have our own guidelines for Bell's palsy published through the American Academy of Otolaryngology, most recently in 2013, the emergency room physicians actually follow their own ER guidelines, and there's an international guideline, and essentially there's a lot of overlap and mostly similarities with these guidelines, but they're not exactly the same. And that can create some discrepancies in maybe what we are expecting as otolaryngologists versus what we're seeing, depending on what guidelines are being followed. So specifically within our guidelines from 2013 from the American Academy of Otolaryngology, we know that there are guidelines that oral steroids should be prescribed within 72 hours in patients that are 16 years and older. There is a recommendation to not order routine imaging and lab work in acute cases of suspected Bell's palsy, which is a trickier thing to stick to for many reasons in the acute emergency room setting. There's also some evidence for certain patients for an antiviral, but essentially, the guideline does state that antivirals alone are not sufficient for treatment, and then that eye health should be monitored closely and preventive treatments initiated if there is any concern, which is truly for most patients when they're in that acute phase. And then finally, we do put in the guidelines that patients should be referred to a facial nerve specialist with any worsening symptoms, persistent symptoms beyond 3 months, and ocular symptoms. So what that means to us when we interpret that as otolaryngologists is that the vast majority of patients should be getting steroids for an acute Bell's palsy, maybe or maybe not with antivirals, usually not, should not usually be getting imaging or lab work unless there's some other reason why it might be indicated in that setting, and that they should be referred to a facial nerve specialist at the 3-month mark. What we became interested in and prompted this study is to really understand where that breakdown comes, because with the number of patients that are diagnosed and the number of patients that we see coming through our doors, there's, of course, a major discrepancy. And then there's all those patients that we see years and years later that were lost to care. So we were hoping to understand where those gaps come in and where we can do better.
So it sounds like there is still a lot of room for variability and variation, even though there are these guidelines. And it kind of depends on which guidelines you read and which guidelines you follow. I can see that would be a very interesting question to answer. So diving a little bit into the article that you and your team wrote, it seems like to answer the question, you performed a retrospective chart review, specifically focusing more on the type of workup, treatment, and the referral patterns of 4 different emergency departments in the region, 2 of them being community emergency departments, a freestanding emergency department, and a tertiary ED. What do you think were some of the limitations or some of the advantages of this approach?
Well, we certainly learned that it was not the easiest study to do. In our system, as you mentioned, we have one main NYU Tisch tertiary ED, and then we have our community-based and freestanding EDs that are within our system and can also funnel into our tertiary center as needed. And so it's as simple as some of the ways that our Epic system works in certain sites and in others is not actually standardized in the way that referrals appear, not in the way that they can place them, but in the way that they appear in a retrospective review and our ability to track them. And so there were some challenges related to that. But in terms of getting to our goal of really understanding the basic patterns of what's happening, we did find that most patients, 90%, did get steroids, we were really happy to see that. I think, I hope that's the case across the country, but of course there's going to be variations, but we were really happy to see that. When we broke it down a little bit further, we did find that about 60% got what we consider to be the right regimen, 50 milligrams for 10 days or 60 milligrams for 5 days with a 5-day taper. 20.5% did not get the right regimen. And when you really distill it down, there were a lot of different answers when we started to look at those individual cases. Some of them were for contraindications, some of the things like patient being diagnosed with COVID or diabetes or other indicators that may have changed the decision-making for that provider. So it's a little bit difficult to parse it out, but we made an attempt to look at those individual cases as well. But most did get steroids to some degree. Many of our patients got steroids and antivirals. Very, very few got only the antivirals. The majority did get some lab work, and about half got some kind of imaging. And so thankfully, nearly every one of our patients did receive eye counseling, which we were really proud of and really happy to see. And then they did, at least in discharge instructions, discharge to a facial nerve specialist. What we thought was really interesting was our finding that a true electronic referral to a facial nerve specialist, whether it was, and we classified this as either ophthalmology, neurology, or ENT, was a significantly smaller percentage. And I think that has more to do with the system itself. And so I think while writing it in discharge instructions can be helpful for some patients, I think there's a lot that can be lost that way. And so there's definitely, this to us represented a really nice area of opportunity for improvement on a system-wide scale.
Yeah, I think to your point, having a referral in the discharge instruction is completely different from physically putting an electronic referral in. A lot of patients wouldn't necessarily know what to do from an action standpoint if they were just told to follow up with a facial nerve specialist, considering the fact that while some of our medical colleagues may know what a facial nerve specialist is, and there's even some discrepancy and variability on that, the layperson couldn't possibly understand or know how to act on such an instruction. So I think the critical part is the electronic referral and the rates of electronic referral. Now, interestingly, you noted that about 1% of patients were referred to ENT in the publication, while the majority of them went to a neurologist and some to an ophthalmologist. How do you think that as a facial nerve specialist and facial plastic surgeon, you can encourage your colleagues or providers in the emergency department to improve that number to really get referrals into the appropriate people and into the appropriate treatment specialists?
I think that's such a great question. I think it begins with education, first with our ED providers, and then second with our other colleagues. So when the vast majority of these patients are sent to neurology or to their primary care doctors for follow-up. And what we found is even at a tertiary care center, many of our neurologists, depending on what they specialize in or how long they've been in practice or who they interface with, really don't know the full extent of the management options that we now have for patients with synkinesis or facial paralysis. The reality is that our field or our little niche of facial paralysis and reanimation has grown significantly in the past couple of decades. And it's going to take some time for the rest of the medical community to catch up to that and really be aware of everything that we can offer to patients. And so I think it all begins with education, speaking to your colleagues, presenting to them, showing them outcomes, showing them patient cases and who it is that we want them to send to us and when. With that, we can really improve the flow. So I think that's part of it is education. The other part is, we're living in an era of digitization of everything, right? So one of the good things that can come out of it is that we can start to automate these things. And that's one effort that we're working with our AD on is to auto-populate a referral to otolaryngology within our department, essentially at the 3-month mark, where patients will be plugged in, either if they don't improve or they're noticing other symptoms like early onset of synkinesis at that point, they will be plugged in. And we're hoping to really help capture those patients and avoid some of the gaps that they receive in care that way. Now, of course, like anything else, it is more complicated. And what about all those patients that do recover by then and then are taking up slots in people's schedules and are no-shows and issues like that? And that's all to be determined. So these are things where it's a little bit challenging, but I think it's worth us putting in the effort to make these workflows as seamless as possible.
I think those are some really good first steps to help spread awareness and help, like you said, invite more people to refer appropriately to the budding niche of facial nerve specialists across the United States. Now, one last question. As you said, some patients are not given a referral at all. And if a patient were to be listening to this episode and they were interested in getting plugged in with a facial nerve specialist, or if they were interested in finding resources to help them get an appropriate referral or even get to the next step in treatment or managing complications of Bell's palsy, what are some resources that you recommend, and how do patients determine an accredited facial nerve center?
Another great question. So I think there's a lot of information and misinformation out there on the internet with Bell's palsy. And unfortunately, some of it is not necessarily good for patients. But the reality is that at this point, I would say most academic centers in this country now have an ENT department and one that has someone that can treat facial paralysis. And so while there are, of course, providers that do a great job managing Bell's palsy and facial paralysis outside of these academic centers, I would say the most surefire way and clearest way to be plugged in with a specialist or someone that can get you to one is to go to your nearest academic center or university hospital, to their ENT department. And even if there they don't have someone specifically that focuses on facial nerve paralysis, I would say the vast majority know the right person or know somebody that they can send you to. And that will hopefully help put you in the right hands.
Dr. Eytan, thank you so much for your insight. It was a pleasure having you. Thank you so much for your contribution to our journal and for forwarding the specialty of facial nerve and facial plastic surgery. Are there any final thoughts you'd like to share?
It was a pleasure. Thank you so much for having me. I would say that for all of us facial plastic surgeons out there with an interest and a passion for treating these patients, just continue speaking with your colleagues in all of your different subspecialties that we interface with and continue to share all the amazing work that you're doing. The more we do that and the more we share the opportunities out there for these patients, the more that we can increase access to their care.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.